Hi, everyone. Today we are talking all about one of the hottest topics out there right now: hormone replacement therapy. If you're a woman in her late 30s, 40s, or 50s going through the lovely roller coaster ride that is perimenopause and menopause and feel so confused and overwhelmed about hormone therapy, this episode is for you. By the end of this episode, you will have a better idea of exactly who it's meant for, why you should consider it, and what it can and cannot do for you. I am so thrilled to be speaking with Carmen Stansberry. She is a double board certified nurse practitioner specializing in women's hormone health, perimenopause, longevity medicine, and the intersection of hormone deficiency with chronic disease risk and immune dysfunction. She is a leading voice in modern midlife health optimization, advocating for women to take charge of their well being beyond outdated medical paradigms. As the founder of the Advanced Practice, Carmen not only built a successful private practice, but also mentors clinicians on how to launch and scale high impact cash based healthcare businesses that provide specialized and forward thinking medical care. Through her expertise in clinical strategy, patient centered care models, and marketing for modern healthcare, she has helped countless providers transition from traditional systems into thriving independent practices that prioritize outcomes, prevention, and patient autonomy. Carmen's approach bridges the gap between clinical expertise and business acumen, ensuring that both patients and practitioners have access to next generation healthcare solutions. Her work has been featured in Very Well Health, Giddy, and multiple podcasts, and she serves as an expert clinical advisor for Hot Flash Inc., a media company dedicated to women's health in midlife. She holds graduate degrees from the George Washington University and Wayne State University and continues to push the conversation forward on women's health, perimenopause, and longevity, ensuring that women receive the evidence based care they deserve. I can't wait for you to take a listen and gain some clarity surrounding this very important topic for women. Welcome to the Lifestyle PA podcast, where we talk about all things women's health and lifestyle to help you become the healthiest and happiest version of yourself. All right, Carmen. So thank you so much for joining me today. I am so excited you're here and to share your expertise and talk all about hormone replacement therapy, which is such a critical component in perimenopause and menopause. Um, so why don't we just kind of kick things off by, can you tell us really what is the role and benefits of hormone replacement therapy or HRT, even in perimenopause?
That is a really loaded question, actually. And the one thing I want to kind of touch on, and you know this because I see your content, is how hormone replacement therapy or hormone therapy in general is just one component of the perimenopause transition and the things that we can do for health promotion and health optimization as we start perimenopause and go through it all the way to the transition into menopause. So I see hormone therapy as an adjunct to all of the other things that are important, like our lifestyle and stress reduction and our nutrition and how we care for our immune system, because our immune system is impacted by all of those factors. And most of the symptoms that women experience are related to inflammation and our immune systems acting up from all of this extra stimulus. And I always say, this is why you could have two friends that are the same age and very similar, and both of them are going through perimenopause in a completely different way. The way that that symptoms are impacting them are completely different. Woman A could have mood swings, weight gain, not sleeping, and just really feeling not like herself. And then the next, woman B is like, gosh, I'm really not having any of those symptoms. I feel really good. My libido is still intact. And all of that is a response to, our environment and the way that we're living overall. So the way I see hormone therapy is it's just really one piece of a bigger puzzle.
You're absolutely right. And it is pretty wild how drastically different women can experience these
Mhm.
things, right? And that's why it really just, in women's health in general, it can't be this cookie cutter approach. Like, you
Right.
really have it has to be like you look at the whole person. And like you said, gut health, inflammation, those are huge parts of what could be triggering the symptoms as well. So let's say a woman comes to you and she's late 30s, early 40s, and has some of those symptoms, right? Like maybe there's occasional night sweats, some increased anxiety, she has some brain fog. And let's say she is working with someone to address those lifestyle factors. What would be some indications to you to say, like, hey, why don't we trial hormone replacement therapy? Like, what would you start with that client?
I think that typically what I start with someone presenting for the first time with these kind of symptoms is a really, really thorough intake of what is actually going on because you have to look at, like you said, their entire life. What is going on nutritionally? How stressful is work? What's happening in your relationship or marriage? Looking at, their personal medical history. For example, pregnancy history can tell us a ton about how women's hormones are functioning and how well they're going to navigate this transition. And so looking at that, taking that intake information, all of the data that we can get, the symptoms, and then synthesizing what actual stage of perimenopause are they in and what else could possibly be going on. You brought up gut health. So, poor gut health can really impact our symptoms and it can also impact our immune system. If we've got leaky gut and poor gut health, we are going to have more inflammation, and inflammation exacerbates symptoms. So, with that intake, looking at the symptoms that they're having, someone like me who's been doing this for nearly 15 years, I could usually look at a symptom intake, cluster them together and know exactly what's going on, to be honest, and exactly what hormones they need, and maybe lifestyle things that they need to start feeling a lot better. So that's kind of where I start, and then looking at those lab values. I won't say that I 100% need those lab values to treat, and this is something that I feel like is a little bit different. I care much less about your actual hormone levels than I do about your hemoglobin A1C, your lipid panel. What is your cholesterol doing? What is your blood sugar doing? Because these are all things that impact then inflammation, then in turn make our symptoms worse. So the first thing is, before I even want to talk about hormone therapy, I need all of that data. And then the other most important thing is, what are her goals? What are her goals? What are her expectations? What do you feel like needs the most attention? How can I help you the most in the shortest amount of time get back to being yourself?
I love that, and I echo all of it and exactly why I do what I do, for sure.
Mhm.
Carmen, can you explain a little bit more about why the lab values are important? We kind of use it to supplement or as a tool for their diagnosis or help with their treatment plan, if you will. But can you tell us why we just can't solely rely on those levels? Like when physicians are checking whether it's estrogen, progesterone, testosterone.
So the biggest thing is that, one, the way the endocrine system works is that our hormone levels are dynamic and they change from day to day depending on what's going on in the rest of our body. And we can't look at just one hormone level in one snapshot in one day and understand what's going on with the reproductive system. There are certain hormones, and we can get into this if you want to. Progesterone fluctuates a lot. We know that progesterone is produced mostly through ovulation. So, but again, if someone has no progesterone because maybe they didn't ovulate, that is going to come out in their symptoms. And so it's very easy to identify. Whereas maybe we check a progesterone level, it's really low, and we know where in the cycle that we checked it. That's going to give us confirmation, not diagnosis. So that's progesterone alone. Estrogen is very similar. It depends on where we are in our cycle. But I don't focus so much on levels as I do to what is the estrogen doing to confirm or deny what I'm already seeing in the symptoms. That said, testosterone is a little bit different, because that is something that we check and we can see, yes, the testosterone level is low. And when we treat, we're going to check it again and see we're going to get a response to treatment. So a thyroid is very similar. That objective data that we're getting from checking those labs is going to give us a lot of guidance. And this is where it can be very confusing for women because they're like, are my labs important or are they not? Why is my doctor telling me they don't need to check my hormones? Well, it depends on what hormone we're talking about. Is it insulin? Is it testosterone? Is it estrogen? And then we can get into the pituitary hormones like follicle stimulating hormone, which is an indicator of menopause, where that's the hormone that's released that's communicating with the ovaries to wake up and produce estrogen. So it's a loaded question and a
No, that
long
was
answer.
yeah, that provided a lot of clarification. I think that's
Hmm.
really helpful. And so tell us, Carmen, because I think a lot of women, because fortunately, there's this recent rise in awareness, but up until today, and I think a lot of women may still be in the dark, many women think, okay, but this is how it's supposed to go and supposed to happen. Like our hormones are
Hmm.
supposed to decline. So why don't I just let it happen and endure the symptoms? And I think many women don't realize just how protective and beneficial estrogen alone is. Can you tell us a little bit more about that?
Estrogen is the most potent anti-inflammatory that we have as women, and that is why we see so much autoimmune disease pop up during pregnancy, postpartum, and then perimenopause and menopause. And so when we look at it just through that lens, we can see how protective estrogen is as we age, because it decreases inflammation, it decreases oxidative stress, and the things that cause, if you've heard the term inflammaging, it's the aging through inflammation. The more inflammation we have, the faster we age in our organs, in our heart, in our vessels, in our brains, and even in our skin. It's how we, appear on the outside. So that in and of itself, estrogen is cardioprotective for that reason, because it decreases inflammation. It's protective in our brains because it decreases inflammation.
Yeah, I mean, I'm super passionate about heart disease in women because, again, we automatically assume, breast cancer is certainly on the rise, but it's heart disease is still the number one
Mhm.
killer. And sometimes when we have women come to us in practice and they're late 40s, early 50s, and that LDL or the bad cholesterol is climbing up, their inflammatory markers are up, and they just kind of chalk it up to, oh yeah, like my mom had high blood pressure, my dad had heart disease, and not really realizing that we can actually do something to significantly decrease their risk for what they're already at higher risk for
Mhm.
genetically, right? Estrogen is so powerful to decrease heart disease risk. Um, so, when it comes to estrogen supplementation, can you tell us a little bit about, like, there are so many forms out there, right? Like, there's patches, there's pills, there's creams. How does a woman know where to start?
And that's what's really hard, because depending on who you ask, sometimes you will get a different answer. I can tell you how I practice and why. I tend to use a transdermal preparation, often like in form of a patch. Usually, there are lots of FDA approved options for bioidentical hormone therapy in, a patch form. That the reason I prefer patch is because there is essentially zero risk for blood clotting issues. When you take away that first pass effect, when we're not taking a medication orally and it's not being metabolized through the liver, it lowers the risk for blood clots. And one of the risks with estrogen can be blood clotting. So that is
Perfect.
my
Okay.
preferred. There are, different cream preparations like a bias, different things that come from compounding pharmacies. And again, I think this is, you know, providing hormone therapy to women, there is an art to it. You really need to understand the patient, their desires, again, that kind of phase of perimenopause to menopause, because those needs change. The amount of estrogen that they're lacking, that can change. How I use estrogen in a perimenopausal woman that's just getting started, and I'm just using it to kind of help blunt the effects of those rapid rises and falls, where they're not necessarily at a point where they're low estrogen. They just have these rapid fluctuations and it's impacting their mood, is different than how I might use, estrogen to treat a woman in late perimenopause and early menopause to prevent bone loss. So it's just it depends on when, and that is again where it's really hard to tell women there's one way or the other to do it. And they really, the most important thing is finding a practitioner that they can trust, that understands these processes.
Yeah, and that's the individualized kind of fun
Mhm.
part of the job, right? Because
Mhm.
again, there is no one standard approach, but it's important to know that there's several modalities. So even though it's always like a trial and error, I find, like even though one form may not help you the most, there are other formulations to try too. I love that you talked about for mood specifically too, because
Mhm.
another thing that I'm finding many women don't realize is the strong connection between that estrogen declining and fluctuating and really its critical role, especially with things like the GABA receptors and
Mhm.
serotonin. And that's why we have these large swings of low mood and increased irritability and anxiety. And often, I was just at an event last night speaking with a couple of women, and I'm telling you, the amount of them that within the past couple of years sought help from their primary care provider, and they were just offered a prescription for an
Mhm.
SSRI, which is a type of antidepressant.
Yep.
Um, and that was it. Like no
Yep.
mention of hormone replacement therapy, no mention of lifestyle therapies and referring. And I feel like it's such an outdated way of practice, and to be honest doesn't even make sense anymore because we actually have recent studies showing that HRT is not only comparable to the effectiveness of an antidepressant or SSRI, in most cases it's superior or can be used as an adjunct with it. And I think that's so important to get that message out to women.
Yeah, it's crazy that it really is, in anyone practicing modern medicine, HRT should be first line therapy for mood disorders in women, because even if we look at the postpartum period, for example, again, we can use medications like pregnenolone and progesterone to treat mood disorders in postpartum. And even if you go looking at PMDD and the pathophysiology behind the mood disorders of just PMS, and even the more severe PMDD, we can use hormones to help women with mood that do not carry the same side effects as SSRIs. Because then we're taking away one problem and adding another. Now we have, maybe the mood is a little bit better and we're carrying a little bit less. We've got, more serotonin available to us, but now we have low libido and weight gain. And it's really unfair to women. I'm glad that you brought that up. And that is the entire lifespan, right? These are women being impacted from their teenage years all the way through menopause. And it's such common practice. And I'm going to say it, I'm going to call it like it is. It's easier. That's the bottom line. It's easier to
Yeah.
write a prescription for Zoloft than it is to have the hormone conversation, to talk about the risks and the side effects. Even though they're so minimal, we're just not used to doing that as clinicians, and we've gotten, I don't want to say lazy, but almost complacent to say, well, this is okay and this is just how we do it, even though what we need to do is flip that script, that we are actually harming women when we don't take the time to have those conversations.
For sure. And I think that's one of the biggest challenges now of kind of conventional medicine and the traditional healthcare system is because, again, how can you possibly have that conversation in a 15-minute visit and then say, okay, I'll see you again in 6 months or a year?
Right,
And
exactly.
yeah, it's just a huge disservice. So, yeah, definitely happy that we're getting that message out there that women deserve better, and there are superior treatments that are easily accessible and still covered by your insurance. That's the best part. So
Yeah, yeah, it's finding a provider that accepts insurance to provide this kind of care, and I think that's where the challenge is coming, and that's also the difference, if I can speak to it, between the traditional medical model treating with hormone therapy is more reactive and symptom based, where a lot of us practitioners that are moving into a more progressive model look at the entire health outcome for women as more preventative. How can we look at the full picture and actually optimize health before they have symptoms and look at what do we know is going to we know what's going to happen when women start perimenopause. We know what the next 10 years is going to look like. Why are we not being proactive to say no, you shouldn't even go 3 months of your life feeling down, depressed, in the dumps, and you should be knowing what's going to happen before it happens.
totally agree. And like that's one reason I'm thankful for social media is because you can
Mhm.
reach so many people and just increase the
Mhm.
awareness because I agree it's kind of an exciting time for providers like ourselves to be part of that shift in that movement because it is
100%.
it is so necessary and honestly should have happened decades ago. But we now have finally a little bit more research on women and making these advances, which is exciting.
Mhm.
Um, I do want to ask you one more question about like the relationship with mood, why we see so many mood swings and anxiety and things like that in perimenopause, because we also talked about progesterone and a lot of my patients who are struggling with the mood symptoms are also not sleeping well at all. Some of
Mhm.
them just pure insomnia, like difficulty falling asleep, and others are waking up 2 to 3 a.m., either just feeling anxious or can't fall back asleep. And I think progesterone can play a very strong role in that for sleep. Have you seen that with your clients as well?
Oh, yeah. Progesterone is what we call nature's Valium. It's our relaxation hormone. And as women, when we don't have enough of it, or we don't, this is the trouble with not ovulating. If progesterone is produced, with ovulation, most of it anyway, and if we don't ovulate, we may notice that impact on our sleep almost immediately. And so that is one of the most amazing things about very easy hormone therapy is let's try some progesterone to see if we can't get you sleeping better and feeling less anxious. And we can use it cyclically. Maybe women only feel that anxiety and insomnia in the second half of their cycle and not as much in the beginning. And we can use it when they are actually having those symptoms. And that's what makes it so great. But that said, we also have a pandemic of doom scrolling and sitting on our phones when we should be going to bed, and we're not producing the melatonin because we're not getting that morning sunlight in our face, because instead we're laying in bed and scrolling, or we're pounding a cappuccino. And what we really should be doing is sitting outside and getting 20 minutes of sunlight in our eyes, so we're producing that melatonin. We're also spending a lot of time stressing about jobs and our kids and all of these pressures that are around us. And so, again, like we've talked about, progesterone is one piece of that, and then the lifestyle on top of it. But I can tell you in my experience that the effects of progesterone on mood, sleep, and anxiety are pretty staggering. I mean, it's really, really amazing what just one little medication can do.
I've found the same as well. And when clients share, they're like, don't even mention progesterone. I've tried it. It had this side effect or it didn't work. And then we dive into there. I'm like, well, tell me what your night looks like. Run me through a typical day, right?
Mhm.
And, they're having a glass or two of wine 2 hours before
Oh,
bed and they're doom scrolling and they wake up at 6 a.m., but they're on their phone until they have to scramble and get the kids ready. And it's like, okay, well, once we kind of, address the lifestyle therapies and get you into a much better routine, build that foundation. And I promise you, if you even still need progesterone at that point, it will be more effective. So it truly is like mastering that combination of both tools. So
Yeah, I think that's the biggest takeaway. You nailed it. And then we didn't even talk about the alcohol factor, and how that
Right.
impacts anxiety and sleep. And that was a really good point to bring up. But yes, that it's never going to be about just one thing. That's the biggest takeaway. Anyone listening to this podcast, it is hormone therapy is a tool, but it is never just going to be that.
Exactly.
Hmm.
And so, Carmen, I actually have quite a few women who, because I feel like perimenopause, again, can start as young as 35. A lot of them are like late 30s, early 40s. And it's that window where they're done having kids. So they're on some form of birth control. And the majority I'm finding may still be the pill. And they're like, well, when we kind of discuss hormone replacement therapy, they're like, well, I'm on the pill. Isn't that the same thing? Can you tell us big differences between what is actually different between hormone replacement therapy and an oral contraceptive?
Yeah, other than the fact that it is synthetic, that is the biggest thing that I don't love about it. And I think that, the issue is birth control pills just independently carry their own side effect risk. For a big one is libido. A lot of women in their late 30s are complaining about libido, but then if you look and they're on a birth control pill, what that does is raises our sex hormone binding globulin, and for those listening, it essentially ties up all of our testosterone, and it impacts our libido quite a bit. And that really is the main difference, is that we're using synthetic hormones in doses that are much higher than what we would actually need to help with symptoms. So it is really, though, a risk versus benefit conversation, because if you have a woman that's having horrendous periods, she's a busy attorney, she's in court 4 days a week, and, she's not sleeping and all of these different things. If she's using a birth control pill and it's working for her and she's 37, I might say, I don't think we need to rush to change that right now. The problem is when and if she needs contraception. I mean, that's a whole nother conversation, right? We still have to
Yeah.
address the fact that perimenopause is a very common time for unexpected pregnancy. And so we have to make sure, depending on obviously their life and goals, that we're covering that base. And so it's very much about risk versus benefit of we're using the birth control pill or we're introducing hormone therapy because it can help with symptoms. That is the one thing, it can help with symptoms.
Such a great point. And I'm so glad that you said, because again, if it comes down to a conversation with the
Mhm.
patient and their lifestyle and risk versus benefit, and if they're not in a season or place of life where they kind of want to rock the boat and kind of, okay, let's change it and see what happens, then don't. Like, there can be a right
Exactly.
time to try
And
things. So,
and that is the problem that I have with some of this messaging, this fear mongering around, "Oh my gosh, you're on the birth control pill and that's not the right treatment." But that's not a sweeping statement, because for many women, like the one I just described, it might be the perfect solution for her. And if we're someone that says, "You know what? I think we should stop this birth control pill right now and we should, approach these things in a more natural, quote unquote, way," that could take 6 to 9 months to get her dialed back in and feeling better after taking that pill away. And so that's why I don't like to use, fear or unnecessary just fear mongering to say you better get off this pill and you better use something bioidentical, because that may not be true to her. And then throwing in an unexpected pregnancy could really, really rock the boat.
absolutely. So again, just approaching it as a whole
Mhm.
person, kind of whole
Mhm.
life situation. You're absolutely right. So let's dive into, kind of the elephant in the room, like this, the WHI, the Women's Health Study, because so many women are still really nervous and they're like, no, I don't want to increase my risk for breast cancer, the significant increased risk for clots and things like that. So can you tell us, like, what is a true contraindication or reason that a woman couldn't start on estrogen or progesterone?
So, when you look at the absolute contraindications, they're actually a little bit different for both, but we'll just kind of look at a sweeping overview. And most women don't realize there are actually very few true contraindications. And if you look at the Menopause Society guidelines, they are really quite clear about that. And again, going back to the fact that there needs to be a conversation, and women carry risks that may not be blatantly obvious, but we need to take into consideration. That was one of the limitations of the WHI study, is that the women we were studying were much older and already had some established heart disease. So then the immediate thought is, well, then we can't give, hormone replacement therapy to women that are at risk for heart disease. Well, it's different when you have a woman who's, 37 with mild hypertension versus a woman who's 65 with, a history of an MI. So when you look at absolute contraindications, it is, one would be an active cancer diagnosis. That's a big one. That estrogen is a growth type of hormone. It will feed cancer growth, especially of the breast or estrogen, dependent cancers. So that would be an absolute contraindication, is an active cancer diagnosis. And then the other thing is too, when we look at actual, it's not the hormone, it's also the delivery and indication, because vaginal estrogen, is not as, and I see you're nodding, that's even a different conversation. So I hate to make these like sweeping generalizations, but absolute contraindication is an active cancer. You need to have a conversation with your oncologist, or your practitioner needs to have a conversation with your oncologist. The next would be blood clotting disorder, something like factor five, homozygous for factor five, history of blood clot, depending on the cause. Again, was it provoked? Was it unprovoked? Was it related to actual estrogen use? Or, but, history of a pulmonary embolism or a blood clot in the lungs or in the leg, maybe post surgically. And even that, it's like we don't want to use an oral estrogen, but maybe looking at the risk and overall picture, that we could consider a transdermal estrogen. Um, and then the other would be undiagnosed vaginal bleeding. A bleeding of any kind that we don't know where it's coming from or why. We need to get to the bottom of that and then maybe consider hormone therapy. But those are really the main, of course, there are going to be rarities and disease processes and pathologies that we really need to take a closer look. But when it comes down to absolute contraindications, you can see there really aren't that many.
I think it was so important. Like this, you brought up such a big limitation too on like why when a woman goes to a PCP and GYN, like that conversation right there, how many providers are having that with women who
Right.
come in and want to explore hormone replacement therapy, right? And I think maybe part of it, whether it's a liability thing, because if they're not current on absolute contraindications or they don't want to risk it because they don't know enough in a 15-minute visit. But this right here really just emphasizes the importance of finding a trusted provider who specializes in this field with hormone replacement therapy, because they will sit down and take that time and just kind of explore what are your risk factors. And ultimately, it will be a shared decision, and the patient can say, I'm willing to accept the risk of XYZ and move forward with that, because quality of life sometimes trumps a little bit of risk, and they're allowed to make that decision.
Yeah. Yeah, exactly. And, one example of this would be people that have a family history of breast cancer. They assume that that's an immediate contraindication. And you hear it a lot. My aunt had breast cancer, so I can't take hormone therapy. Well, who told you that? Because that's actually not true. And that is why we have so many advancements in genetic testing. That we can look at these genetic tests. We have really good ways of coming up with, this is your actual risk. Here are the ways that we can increase your screening, not make you suffer, and worry about these things that may never come to fruition, but just increase the screening that we're doing and have this risk versus benefit conversation. Because if a woman's having 30 hot flashes a day, every single day, and she can no longer go to work, we're going to weigh that against, your aunt had, breast cancer, and this may not even be increasing your risk at all.
Absolutely. And I love how with the different formulations, like especially patches, you can look at it as a trial. Like just
Mhm.
because you don't have to commit to it for the rest of your life, right? Like try it out, see how you feel for a couple of months. And if you're not noticing much of a difference, okay, then we can discontinue or try something else. But a lot of the times it's going to be significant improvement. But at least knowing you have that option to
Mhm.
discontinue it whenever you want. And actually, speaking of that, Carmen, so how long can you stay on HRT for?
And that is one of those things I think it's, they're kind of saying now that there really is no end date. There is, I was part of that when I started practicing in 2011. It was very much this, we're going to give you the lowest dose for the shortest amount of time to help you with symptoms. And that's it. That was like the conversation I had over and over and over. I still think about it now, how many women that were, I don't want to say harmed, because we do the best with the information that we have, but now it is this, again, a very personalized decision making process that if you're over 70 and you're feeling really good, and who am I to say, you have to go off your hormone therapy right now, because we don't really know that to be true. And I think this is why it's so important that we continue to advocate for more research, that as we go and more women are using hormone therapy, that we continue to monitor. But what we're really finding is there is no set end date.
Perfect. Okay. Yeah. And I mean, definitely supporting ongoing research because women,
Mhm.
we're very late to the game. We have a lot to make up for, right?
Yeah,
So, and even
exactly.
just the past 5 years or so too, even being up to date on the research as far as, nutrition and fitness surrounding this area and perimenopause and menopause. It's fascinating. Like we are truly wildly different than men, which is what the majority
Mhm.
of research has been on. So, it's again just kind of exciting to be part of like no we have a targeted approach and we're very different human beings on a hormonal and metabolic level in this season of life, but we have things that can help and be effective.
Mhm.
So it's exciting. So
Yeah.
Carmen, can you tell us kind of as we wrap up here, what is the best way? So I know you're based in Southern California, right?
Northern.
Northern,
San
sorry, you're San
Francisco,
Francisco.
Bay Area. Yeah, it's
Yes.
okay.
Yeah. So can you tell us how, so for even like women nationwide, like is there a resource you have them go to find these specialized providers if they're interested in exploring HRT?
I think it's hard. I'm gonna just say that it is very challenging still to this day. There are resources out there, and you kind of hear a mixed story. So I don't want to say this in 100% certainty, but the National Menopause Society, they do have a list of practitioners that are available and certified to do menopause medicine, and so that's a great place to start. And I know Mary Claire Haver, who does a lot of speaking and advocacy around menopause, has also created a database of providers that are providing hormone therapy. The landscape is very, very confusing for women, and this is why I recently put out some information just about the difference between medical model focused hormone therapy, symptom based, and women can go to their OBGYN with, symptoms and say, I have this, I'm very interested in starting hormone therapy. I think every month and week that pass, we are getting more people more willing, more educated to provide hormone therapy in these conventional settings. And then you have, a lot of people out there that are taking more of a functional medicine approach, more of a health optimization approach, and that just varies. You kind of look in your community and using Google honestly and start interviewing people and seeing what you can find that's out there, because unfortunately I wish someone would come up with a better resource, honestly. And I wish a lot of the messaging around this was more consistent, because a lot of it is marketing and people can say whatever it is they want to say, from conventional medicine to med spas. Even it's, we do hormones, it's like, what does that actually mean? And that's where it's really important. So as you know, just like I do, there are a lot of different options, but those are some ways I think women can find someone, at least a place to start.
Yeah, thank you. And I hope we get there too. Just more of kind of clear, consistent messaging because you're absolutely right. They see hormones and just assume
Yeah.
XYZ. So it would be nice to have just like one central point of resources and and things like that. But same, Menopause Society is typically my go-to as well, because it will list providers there with the
Mhm.
experience. But one more thing to add to our list to advocate for, right, Carmen? So
Yes, exactly. Get this
we'll
information to women where they need it. Mhm.
yeah, we'll get there. And for our listeners, what I'll do is I will provide those websites for you under for the links for the episode, and I will put Carmen's Instagram name on there so you can follow her as well. Super useful information. So, Carmen, thank you so much for today. This has been an amazing conversation that I hope reaches a lot of women. And honestly, even if it's only one, you've helped them a ton. So, thank you so much.
Yes, great. Thank you so much for having me. This was great.
Thanks, Carmen. If you're ready to invest in yourself to become the healthiest and happiest version of you, head over to my website, thelifestylepa.org, to learn more about my 3-month lifestyle program, where I offer a very personalized, whole body approach to optimize your health. In addition to your 1-hour initial consultation, we have 30-minute bi-weekly Zoom visits. You receive my 45-page lifestyle handbook, lab work interpretation, unlimited communication and support through a secure messaging platform, 3 months of meal plans tailored to your needs, and guidance on mastering the 6 pillars of lifelong health: nutrition, movement, sleep, stress management, positive psychology, and social connections. I can't wait to connect with you and help you to truly optimize your health once and for all.